if I focus on frontline older patient treatment, we had a recent meeting in the UK for the European Working Group.
We should focus on a frontline.
I'm sorry?
Hervé, I agree with you. We should focus on a frontline more than
because
other end.
I think that could be more productive to focus on frontline. Okay, thank you, Elias. So if I focus on frontline management, we had a recent meeting in York, in the UK, with EWAL members. That's adult ALL, that's European Cooperative Group, and we discussed a lot of things together. It was a very interesting meeting as usual. And okay, what we had presented, and it's also a review of the ongoing trial at the global level, is that some trial try to incorporate inotuzumab with minimal chemotherapy, or even inotuzumab alone during the first cycles. So this has been developed as a pioneer by Elias and colleagues in Houston with so-called mini hyper-CV protocol. And then it with very good result, actually, and very good survival despite few transplantation. And then it has been confirmed in Europe by our colleagues in Europe, and presented, not yet published, but it will be published shortly, in the EWAL group, so-called EWAL-INO trial, which is basically the same spirit. And good results were produced. I mean, when I say good result, it's survival at, let's say, 4 or 5 years around 45 to 50%, which is good for older patients with B ALL. And there is a third trial coming from Germany, so-called, I mean, the acronym Initial-1 trial, also with and relatively maybe more dose chemotherapy. So this is a way to treat older patient frontline. The other drug is obviously blinatumomab, and this has been probably less developed. We have a trial in Germany, the BOLD trial conducted by Nicolas Gottbiget, with relatively few patients, but good result as well. And obviously, the obvious idea is to combine both. I mean, to try to reduce the intensity and the toxicity of standard chemotherapy and to base the treatment of the new drugs. And a combination of inotuzumab and blinatumomab, not simultaneously, but sequentially. And this has been developed by the MD Anderson Cancer Center again. So this is, for me, what is happening currently to treat older patients with B lineage ALL. And the second point, or the second question, is maybe a bit contradictory to that, is the use of transplantation in older ALL patients, and especially reduced intensity conditioning transplantation. We do not have, I do not have, maybe it's my fault, but I do not have a clear idea of the result of RIC transplantation in older patients with B lineage ALL. I guess that the result of RIC transplantation will depend on what is given prior to transplantation, especially if prior treatment include or blinatumomab. So for me, this is the landscape currently. I do not see currently any big place, not yet, for CAR T-cell in frontline treatment of older patients with BLN. Maybe I'm wrong, maybe it's developed. You can comment on that. So this is just to launch the discussion.
Yeah, I have a comment, Hervé. Despite all these advances, at least in our center, we're still seeing death in CR in older patients. And then we're exploring, as well as the Alliance, no chemotherapy at all. to see if we can decrease the rate of adverse events. And mainly what we've seen as well, secondary MDS AML emerging. And this can be problematic at the long run.
Absolutely, correct.
Ellie, I didn't quite hear that. What did you say was emerging?
We're seeing MDS AML clones emerging in a mini CVD in Oblina. We have 80 patients, and we have 9 patients after a follow-up of 3 years having MDS AML. In retrospect, this patient had P53 clone present up front, and we thought at that time it's an AML clone. In the context of hypodiploidy, it turned to be, by doing single-cell sequencing, it's a SHIP, it's a myeloclone present that led to AML down the road.
So maybe we can, if there is no other comment, maybe a brief roundtable to just to say what is your current treatment of older patients with B lineage ALL.
I can start in patients who are 60 and older at Anderson. We're doing a dose-dense mini CVD in Oblina, so in Oblina together up front. And what we're doing, we're shorting the blina. We're adding it on day 4 to day 21 of a cycle, 18 days. For 6 cycles, 4 of them with inotuzumab. And for patients who are 70 years and older, we give them inoblina, no chemotherapy at all, just vincristine steroid for the first cycle, try to reduce, and then inoblina concomitantly, no maintenance phase to be offered anymore. And then we're part of the Golden Gate 360 trial, where we're testing in a randomized trial blina upfront with low-dose chemotherapy versus those adjusted hyper-CVAD.
Very good.
Yeah, in the Netherlands, I can explain what we do, but we give for elderly patients chemotherapy, depending on age, how intensive it will be. And if they are MRD positive after the consolidation, we switch to blinatumomab, where it's registered and reimbursed for. And once they have the eligibility and age for a stem cell transplantation, we then move on with a reduced intensity stem cell transplantation in this age group. We don't use inotuzumab up front. And CAR T-cell are not reimbursed, only for a small amount of patients. We can get reimbursement in elderly patients. So that's how we do it in the Netherlands.
There is a trial just starting. I think it's only in Europe. I don't know. Anita, you can correct me, or the other, testing the addition of blina frontline to standard chemo, let's say, in older patients. So
yeah, in Germany, they're gonna reimburse it, huh? But not in the other countries. You mean MRD negative?
No, I mean in all patients.
So there is a global trial for blina in first line, a global phase 3 trial.
Yes.
Comparing blina plus attenuated chemo versus the standard of care.
Absolutely, that's the trial I have in mind. So this is a trial without inotuzumab. It's only testing the addition of blina. So maybe it's not as advanced as the Houston experience, obviously, but this is also something to be mentioned.
Correct.
Well, Ellie, isn't the Golden Gate trial, is that international?
Yeah. This is the Golden Gate trial, correct?
Yeah. So I have an issue with Ino. Maybe Elias, you can comment on that, but I don't know what is the optimal dosing of inotuzumab, because it's very different from one trial to another. I mentioned 3 trials. I know you started in the early beginning, Elias, with quite high doses, and you reduce them after. In Europe, we use reduced dose of Ino. In Germany, there's full dose of Ino. So there is also an issue of Ino dosing and scheduling.
In a relapse setting, when we use a full dose of inotuzumab, we've seen the VOD above 3 milligram meter square. So we decided to limit our dose to 2.7 milligram per meter square, given 0.9 for first cycle and 0.6 for subsequent cycles. And now in our strategy with combination in older patients, we never go above 2.7 milligram per meter square.
Yeah, I think it's
given by week at a low dose.
Yeah.
And in a relapse setting, when we did this strategy with a long follow-up today, we were able to reduce the VOD rate from 13% to 1%, which is quite good.
Very good. Other comment or experience? What about transplantation? Is there any trial ongoing for your knowledge?
I don't know any trial. Most data are from registries.
Yes, or retrospective, and low number of patients usually.